Good morning, teachers. I'm Dr. Ravitej from second year resident from Manipal Hospitals, Bangalore. I would like to talk about the TRAS data of the last 2 years at our center. Introduction: the 5-year graft loss due to rejection has reduced to around 20 to 30% because of robust immunosuppression which has come into place. Other complications, including vascular complication of transplant renal artery stenosis, has come to the forefront. Transplant renal artery stenosis causes graft dysfunction directly by reducing the blood flow and indirectly by causing accelerated hypertension. The pathophysiology of TRAS is explained by one kidney, one clip model of Goldblatt in the 1930s. The non-invasive diagnosis by it can be non-invasive or invasive procedure. Non-invasive procedures include duplex and isotope renography, which is less used nowadays, CT and contrast enhanced MRI, which both have high specificity and sensitivity. Invasive modalities include conventional angiography and the gold standard digital subtraction angiography. There are 3 treatment modalities which can be used, including medical therapy alone, medical therapy with PTRA, that is percutaneous transluminal angioplasty, and surgical revascularization. When medical therapy is started and the patient continues to have uncontrolled hypertension and declining renal function and progressive of stenosis on follow-up ultrasound, surgical or PTRA revascularization should be done. Objective of the study, I'll be going through each one in the results below. Materials and methods: it's a retrospective study. This study occurred in Manipal Hospitals in Bangalore during the years 2023 and 2024. Patient selection: I would like to quote the definition which you took for significant renal artery stenosis. It was recent worsening of hypertension or worsening allograft function and worsening symptoms explained by TRAS when all the other causes were ruled out. Variables: we went through that studies which have quoted in the references and took the variables from them, and few of the variables like PSV on postoperative day 1 here was added by us. I'll go through each of the variables below in the results. Total 205 patients underwent transplant at our center during those last 2 years. In all, 18 patients were analyzed to have significant transplant renal artery stenosis. Recipients was characterized by average age of 45 years, the age ranging from 18 to 65 with a male preponderance of 89%. 8 patients had diabetes, all but 1 had hypertension. 7 patients had infliction of one of the vascular territory. In those, 4 had coronary artery disease and 3 had severe peripheral vascular disease. The most common native kidney disease when it was known by biopsy was IgA nephropathy, followed by diabetic nephropathy. We also had 1 case of VUR. Donor characteristics was characterized by bulk of donors being female, and the average age was 47 years, ranging from 23 to 67. 3 donors had comorbidities where 1 had diabetes and 2 others had hypertension. This is the chart representing the same. Transplant characteristics: all were live transplant except 2 which were diseased donor renal transplant. 2 transplants were robotic while all other were either open or laparoscopic. All patients received a left side kidney. 4 patients had 2 renal arteries and 1 patient had 3 renal arteries while all others had single renal vessels. All except 1 were end-to-side anastomosis to external iliac vessels, while 1 person who went end-to-end anastomosis to internal iliac vessel. The average ischemia time was 104 minutes, which was skewed by a case of diseased donor renal transplant where the ischemia time was very high, 826 minutes. After excluding the same, the other diseased donor was in-house cadaver, so it was less in that. Excluding the 826 data, we have average ischemia time of 61 minutes with a range of 40 to 80 minutes. Post-transplant outcomes: none of the patients had CMV illness and biopsy-proven rejection at follow-up. Early postoperative renal Doppler imaging in the postoperative day 1 was aberrant in 2 of the patients where PSV was 438 and 353. In them, it was conservatively managed, and on follow-up, they reached their nadir creatinine. This is the same representation. Clinical characteristics at the time of presentation for TRAS: the average time of diagnosis of TRAS was 6 months. 13 of the 18 patients had allograft dysfunction. Renal replacement therapy was not needed in any of them. Out of the 18, 11 experienced recent worsening of hypertension. Investigation characters: the average PSV was 375 with a range of 30 to 600. I'll be talking about the 30 later. TRAS was confirmed by CT angiography in 5 patients, that is 27%, and MR angiogram by 44%. Treatment characteristics, 5 of the patients continued on conservative management. They had a normal allograft function at presentation, but they had other symptoms suggestive of TRAS. 13 patients, the remaining 13 patients underwent PTRA. None of the patients underwent surgical repair. Drug-eluting stent, Resolute Onyx, was used in 7 patients, and a bare metal stent, Herculink, was used in the other remaining 5 patients. 1 patient experienced immediate post-operative hematoma at the access site, which was conservatively managed and resolved in few days. Post-procedure outcomes being, after the procedure, all patients' creatinine showed a downward trend. 4 patients had 22% of the patient had normal allograft renal function. 55 patients had allograft dysfunction, but it was extremely close to their prior baseline. 16% patients still continued to have chronic allograft dysfunction, but the average creatinine was around 1.49 mg per deciliter. The required number of antihypertensive dropped in all of patients except 1 by 1. In that patient, it rose by 1 actually. Correlation analysis to see any statistical significance was there with TRAS, and other variables are given below. We analyzed TRAS with peripheral vascular disease, coronary disease, CVA, type of transplant follow-up. We try to correlate all the, initially all the variables and then one variable with each other. Mainly was TRAS, and other variables were follow-up creatinine, peak creatinine, number of antihypertensive, edema at presentation, and allograft dysfunction for any statistical significance. Below are the positive correlations we found. Creatinine at follow-up was, I'll go in discussion. Due to its direct impact and indirect impact, RAS causes renal dysfunction. The average prevalence was 8.78% with male preborn trends and an average age of 48. Frank P. Hurst, with a seminal study on USRDS, found the following risk factors. Donors and recipients' old age age range from 18 to 65. Extended criteria donor, we had most of them live related renal transplant. Induction, most of the were ATG, and recipient comorbidities. We had a significant comorbidities with 44% having diabetes and 38% vascular affliction in 4 coronary artery disease and 3 having severe peripheral vascular disease. Delayed graft function, which was found in 2 cadaver patients. Ischemia time was 61 minutes. Time of TRAS detection was around 6 months. Ours found no association of TRAS with cytomegalovirus and rejection, which were not found in our study. Non-emergible risk factors by Krishnamurthy study et al. Was harvesting right kidney because of double length of the artery. We had all left. Disease due to renal transplant was 2. Intimal tear during perfusion in live, we had open and laparoscopic in majority 61%. NKD was IgA, okay. With a range of 30 to 16, that 30 patient, a strong clinical. You
can sum up, doctor.
Summarize.
Conclude.
We had a recent increase in number of TRAS patients, so we wanted to see if the standard risks which were published previously still holds good here. It did hold good, but a few things we added to see did show a positive correlation, like higher PSV at initial post-operative days did show a positive correlation, and this again underlines the importance that higher creatinine at presentation and late detection will cause there is allograft dysfunction in the long term. And one more important thing, what we found was ultrasound is very determinant on who does, and sometimes many of the patients we had showed very high PSV values on ultrasound, and eventually on other non-invasive procedure itself, like MR angiogram and CT angiogram, they were found to not have TRAS. So it is very procedure dependent, and ultrasound should be taken with should be followed up with the same radiologist. Thank you.